Welcome, everybody. Good afternoon. Thank you for joining us on this webinar looking at tackling polypharmacy in primary care. I'm very pleased to chair this session for you. My name is Jenny Scott, and I'm a pharmacist academic at the Centre for Academic Primary Care at University of Bristol. We're hearing today about the IMP clinical trial. We have two speakers who are going to talk to you today. And I've just introduced them. They're going to each talk twice, so I'll do both introductions right now and then hand over to them to deliver the session. So first of all, we have Professor Rupert Payne. He's a senior academic GP and a clinical pharmacologist. He trained in Edinburgh and Cambridge before moving to senior lecturer position in Bristol. He's been Professor of Primary Care and Clinical Pharmacology at University of Exeter since 2022. He's got a long-standing interest in polypharmacy, and he's published widely on the subject, including authoring influential King's Fund report in 2013, which is still referenced. He was the chief investigator for the IMP clinical trial that you're going to hear about today. And that trial was a direct response to a call for evidence from NIHR on how we can improve care for the growing number of patients who experience polypharmacy in modern clinical practice. Rupert's practicing GP in North Somerset, and he's a former chair of the UK Society of Academic Primary Care. Our second speaker, Dr. Deborah McCacken, is a senior research fellow at Bristol Medical School. Deborah's expertise is in medicines optimization, polypharmacy, and primary care research. She leads and collaborates on studies that improve prescribing and patient experience, and she managed the IMP trial. Deborah has published extensively, contributing to evidence on safe and patient-centered use of medicines. So welcome to both of you. I'm going to hand over now to Rupert to start the presentation. Thank you.
Thank you very much, Jenny. And it's nice to have lots of people joining us today. Appreciate the chance to present this work that we've done over a number of years and struggled through various problems like global pandemics and so on. So it's great to have seen it come to an end, and we're going to talk about what some of the findings from it might mean to the way we manage polypharmacy in primary care today. So to start with, I thought I'm going to go through the background of what's going on, and then Debbie will carry on after that to talk about how we approached it. So polypharmacy, how big a problem is it? Well, you can see in the graph on the left, this is one of the first studies we published actually in the epidemiology of polypharmacy, showing an increasing number of drugs, unsurprisingly, as you get older. And by the time you're in your 70s, about a third of people are on 7 or more long-term medicines. And this has been an increasing trend over the number of years. You can see the graph in the middle over the last 25 years or so, a doubling in the amount of, more than doubling in the number of medicines being dispensed in primary care. And it's not just the UK, as you can see on the map on the right. It's a global issue affecting Europe, North America, and indeed the so-called transitional nations. But a big problem. It's something that has also been recognised by policy makers. So the NHS Business Services Authority have developed a number of metrics for measuring polypharmacy to allow practices to see how much multiple prescribing is going on in their practices. The Department of Health published a report on overprescribing 4 years ago. Now I think it was discussing the challenge of the problem, and as a response to that, the NHS England appointed a new director of prescribing for the NHS, Tony Avery, to try and tackle the problem. And indeed, there's also been cross-party activity. There's a all-party parliamentary group that looks at this issue. So it's certainly well recognised now. And it's not just why does it happen? Well, it's not just the fact that we have an aging population. We also have people with multiple long-term conditions. Those people with multiple conditions account for about 4/5 of all prescriptions, and compared with people who don't have multiple conditions, take 6 times as many medicines. So there's a big challenge there, and there are lots of other factors here highlighted in this slide. Single condition guidelines that sort of promote increased use of medicines rather than necessarily stopping them. A poor evidence base underpinning care, issues like increasing clinical complexity, of course, the burden of workload on overstretched clinicians, a lack of training, various sociocultural issues as well. So lots of different factors all feed together to lead to multiple prescribing. And it matters because it's got adverse consequences. So for every additional one regular medication that someone takes, there's a 10% increase in the number of side effect related admissions to hospital and a 16% rise in prescribing errors. And indeed, if you take for people on more than 10 medicines, it's been noted that an 8% reduction in quality of life. So this has real impact, adverse impacts on patients. So what do we do about it? What's the evidence for fixing polypharmacy? So there's certainly a number of studies that have looked at focused interventions, looking at specific safety issues. So the graph on the top left is data from the Pincer study that many of people on this webinar probably have heard of. Pincer was a complex intervention involving pharmacists and an educational program to try and address various aspects of inappropriate prescribing, and it did indeed find that it could reduce the use of non-steroidals for people with peptic ulcer disease, for example, who didn't have any gastroprotection, and reducing the use of beta blockers in people with asthma. There were a few things that it improved, very specific problems. And some in the graph on the left, the bottom left, is results from Tobias Dreschelt's DQIP study, which showed a focus specifically on high-risk prescribing related to GI bleeding. And they found, as you can see in the middle bit of that graph, a sudden drop with their intervention in the amount of potentially problematic prescribing. And importantly, that was sustained after cessation of the intervention. So these interventions focused on specific things work. But actually, what about more generic interventions which are required for dealing with people on multiple medicines? Well, the evidence, actually, we did a review, you could see here, back in a few years back now, showing that the evidence for isolated medication reviews, so reviews without all the bells and whistles, is actually very limited. So the bars show the number of studies that looked at various things like clinical efficacy at the top there, cost reduction, the second one, mortality. Down at the bottom, we have quality of life and unplanned admissions. And the blue parts of those bars are the studies that actually showed some sort of benefit. And as you can see, generally those bars are grey. There's very little blue. There was very little evidence there, certainly not consistent evidence for improvements. The isolated medication reviews improve things beyond some benefits for total number of medicines, drug-related problems and adherence, but certainly not for other important issues such as mortality, quality of life, and hospital admission. Some of you may have heard of the IMPPP study. This was a major study, EU-funded project that looked at polypharmacy prevention using a pharmacist-led comprehensive review. It was very comprehensive, 28 hours of training for pharmacists, 2.5-hour intervention in total. They studied 3,000 patients. It was not a randomized study, however. It was a before and after study. They did see a decrease in number of medicines from 12 to 11, a slight decrease in inappropriate prescribing, and some potential economic benefits modeled on the changes in medicines they found. They didn't report another outcomes such as admissions or death, and it was a non-randomized study. And there was a large amount of work, 28 hours of training and 2.5-hour intervention per patient to achieve those changes. So it in itself probably isn't the solution. Has been a Cochrane review published 3 years ago by Carmel Hughes and colleagues in Belfast. showing again some evidence for reductions in inappropriate prescribing and omissions and things like that. But actually, the strength of that evidence is actually pretty weak. There was another study, more recent review published last year by Tony Avery and colleagues in Nottingham, finding, again, relatively limited evidence for primary care interventions. There were some decreases in admissions from pharmacist-led interventions, but no improvements in admitted patient numbers, no impact of training, clinical decision support tools, emergency department visits and deaths. So this is, again, a systematic review. So limited evidence for effectiveness. And finally, of course, structured medication reviews have been rolled out recently, and I think lots of people hope that the purpose of that was to try and address overprescribing. Colleagues in Oxford, James Shepherd and others have been working on looking at evaluating the effectiveness of these structured medication reviews. And again, from early work by Mary Madden, some qualitative work suggests that they probably aren't achieving what they were setting out to do. And certainly the benefits looking at from an epidemiological perspective suggest limited improvement in inappropriate prescribing and structured medication reviews. So we do need better evidence, and that evidence needs to be high quality and needs to align with practice needs, and it needs to address the limitations of some of the current strategies that we're employing. This is where the IMP study came in, and we were focusing on 3 key areas, and that was how we might go about identifying the population of interest in the first place, delivering and implementing effective reviews, and modifying aggravating factors. So I'm going to hand over now to Debbie, who's going to talk us through how we actually went about that. Debbie, you're still on mute.
It's on mute, Debbie.
Sorry.
Thank you.
Apologies. Yes, so thank you, Rupert. We're going to have a look at the intervention and the trial design now. So if you remember, Rupert highlighted the 3 key things that we need to are needed to effectively reduce inappropriate polypharmacy in primary care. So identification of those people most likely to benefit. We need to address the factors that get in the way, and we also need to ensure that medication reviews themselves are effective. So our trial design incorporated all of these elements. And you can see at the top there on the left, to support engagement with medicines optimization, we included performance feedback to practices, so that practices could identify where the problems existed and monitor progress over time. We also provided training for clinicians to support more evidence-based practice, alongside financial incentives to help make this work a priority in routine care. And then at the core of the intervention is a structured 5-stage medication review process. And this begins with automated identification of patients using electronic health records, followed by a pharmacist case note review without the patient. Then an interprofessional collaborative discussion between the pharmacist and GP, bringing together complementary expertise to discuss and agree what would be taken forward to the patient-facing review. And this interprofessional discussion, we asked that professionals got together in person by telephone or video call to actually have an interactive discussion, one-to-one. So next came the patient-facing medication review, and finally follow-up was provided where clinically indicated. So underpinning all of this, an interactive informatics tool was used to support the case finding, enable the performance feedback, and importantly, provide an interactive summary of key clinical information to support decision-making during the medication review. So the clinical summary could be accessed on demand by clinicians via a small light bulb icon, which appeared when the EMIS clinical system was active. And this then popped up a window which provided a text box for recording unstructured written clinical notes, and also 5 principal tabs giving the user quick access to key information within the clinical record. So on the first tab, there was a summary of core clinical information, including things like smoking status, weight, blood pressure, important blood test results, and then key diagnoses. The second tab provided a list of the repeat medications alongside a graphical display of medication adherence and also common side effects, as well as a list of recent acute medicines and all drug allergies. And the third tab displayed a list of the potentially inappropriate prescribing indicators currently triggered by the patient. The next tab gave access to a historical list of review activities and written documents, and also clinical codes recorded at previous encounters. And then the final tab allowed the clinicians to record coded information about the review itself, including next steps in the process. And any of the notes that were entered by clinicians in this summary tool were then saved into the EMIS record. So the trial design, we look to identify any adults on 5 or more regular medicines with at least one measure of potentially problematic prescribing. And we asked the practices to randomly select 300 patients, of which up to 50 were then invited to a review as part of the study, and patients were recruited before randomization. So we had 37 practices that took part, and patients in half of the practices received the structured review intervention that I've just described, with patients in the other half of the practices continuing to receive routine care. And IMP reviews were spread out over a period of 6 months to those 50 selected patients. So patients in both arms followed exactly the same processes, including completing a pre-review survey. And those in the intervention arm received the IMP intervention and a post-review patient experience survey. And then we followed up all of the patients for a period of 6 months. So what did usual care look like? Well, typically usual care involved a single routine annual medication review with no specific strategy focused on polypharmacy. Pharmacists were not necessarily involved in those medication reviews, and practices in the control group did not have any of the additional supports we built in. So there was no dedicated training, performance feedback, clinical summary tool, or financial incentives. The practices participating in the study were distributed across the West Midlands area and the areas around Bristol, as shown on the map here. They were relatively typical of the national picture. So the average list size was just under 11,000, ranging from 4,500 to 50,000, and with a good range of socioeconomic deprivation. 30 of the practices had pharmacists, and of the 37 practices, 19 practices were allocated randomly to the intervention arm, and the remaining 18 continued with usual care. So I briefly mentioned the population before, but, so you're aware that there were 50 patients in every practice, and this gave us a total of around 1,850 patients in the trial. They were all adults with 5 or more regular medicines and triggering at least one indicator of potentially inappropriate prescribing. So the primary outcome for the trial was the mean number of potentially inappropriate prescribing indicators per patient. And this was based on a list of over 100 indicators drawn from sources like STOP and START. And the indicators were grouped into clinically meaningful categories. So, for example, indicators associated with risk of bleeding or acute kidney injury. And just to give you some examples, one of the indicators included prescribing an ACE inhibitor, a diuretic, a diuretic, and a non-steroidal anti-inflammatory drug together, which increases acute kidney injury risk. And another was a prescribing of an aspirin in someone over 65 with a proton pump inhibitor, without PPI, increasing the risk of gastrointestinal bleeding. In terms of our secondary outcomes, we included patient-reported measures such as quality of life, treatment burden, medicines literacy, and also adherence. Alongside, we measured service utilization, which included GP consultations and hospital admissions. We also recorded deaths. And all of our outcomes were assessed at 26 weeks using an intention to treat analysis. In parallel, we conducted a mixed methods process evaluation to examine adoption and delivery of the intervention, and also to explore patient and clinician experiences. So we collected data through patient surveys, interviews with patients and clinicians, and we undertook observations and audio recorded a subset of medication reviews with patients, and also those interprofessional discussions that I mentioned earlier between GPs and pharmacists. And we carried out a health economic evaluation to see whether the intervention offered good value for money from the NHS perspective. And to do this, we assigned costs to prescriptions, GP and nurse consultations, and hospital visits using information from clinical records. And we use the data to calculate QALYs, which are a way of showing how much an intervention improves people's health and well-being, and to help decide if it's good value for money for the NHS. So I'm going to hand back to Rupert to take you through some of the results.
Thanks, Debbie. So what did we actually find then? This is a description of the patients who participated in the study. As with all randomized trials, you want to make sure that it's relatively similar between the two arms of a trial, and we find that in the usual care and the intervention arms, indeed, it was pretty similar. So a roughly 50-50 gender split, an average age of about 73 years. The majority of patients were of white ethnicity. That is a common problem with clinical trials, unfortunately, and they were probably slightly better educated than the average population of this age group, around 18% with a degree qualification. On average, 4 long-term comorbidities, and they took 8 regular medications on average, and triggered on average per person 2.3 to 2.4 potentially inappropriate measures of potentially inappropriate prescribing. So similar between the two arms. How was the intervention actually implemented? Well, we managed to successfully roll out an IT tool across the practices, which was, shall we say, a little clunky, but did do what it needed to do. We had very positive feedback on the training that we delivered to pharmacists and GPs alike in practices, and the performance feedback reports that we gave to practices on a monthly basis. You can see a screenshot of the front page of one there. Those were successfully delivered and well received by practices. The actual review process itself, of course, we were trying to get 100% ideally of all these reviews. There were 3 different stages, as Debbie's already said. 98% of all the expected case note reviews were indeed carried out. 95% of all the interprofessional discussions were carried out between the GP and the pharmacist, and 89% of patient-facing reviews were completed. So this was actually considered very good. You can see that some practices managed 100% of the first couple of parts of the review process, and 98% for patient-facing reviews. There was one practice which was was less good, shall we say, at engaging. But this is, we think, generally is a high proportion of reviews being completed, which is excellent, and probably reflects what would be achievable in real world practice. And then after, several years and blood, sweat and tears and so on, and 2 million quid of taxpayer money, what do we find? Well, essentially, our primary outcome demonstrated that there was no evidence that our intervention is any different to usual care in reducing potentially inappropriate prescribing. A p-value of 0.95, very convincing that there's no evidence whatsoever. And we looked at a number of aspects of that. So we looked at whether it was affected by things like the compliance with the intervention by the practices. We had a couple of practices that switched from EMIS to System 1. We looked at whether that had any impact and ruled out any, looked at outlying data as well. That didn't seem to have any impact, and nor did various socio-demographic factors such as sex, age, socioeconomic deprivation, and importantly, mental health, which we felt might impact people's willingness to engage. The one interesting thing was that potentially inappropriate prescribing, there was a hint, and the p-values there of 0.08, there was a hint that people with lower numbers of medicines and lower levels of multimorbidity did seem to have a slight improvement in the right direction in terms of reductions in potentially inappropriate prescribing. But this is a secondary analysis and wasn't, strictly speaking, statistically significant. We did look at various secondary outcomes as well. There were no impacts on medication count or adherence or indeed quality of life. But interestingly, we did show a slight improvement in treatment burden. This is the first major trial I'm aware of, certainly, that has shown a significant improvement in that outcome measure. And then our health economics, perhaps unsurprisingly, given the lack of significant clinical outcome, we found that the mean number of quality adjusted life years was similar in the two groups. Costs were, again, unsurprisingly, a little higher in the intervention group because we were doing stuff. It cost just over £5,000 to prevent one potentially inappropriate prescribing indicator. And the chances of us actually meeting the NICE threshold, which is set at about £20,000 per QALY, for NICE to consider an intervention worthwhile, there's only a 6% chance of that threshold being met. So generally not considered a cost-effective intervention. There were important strengths to the study. It was one of the largest randomized trials of its type. It was well designed. The intervention was implementable in the real world, achievable in practice, and because we use routine data to capture a lot of the prescribing information, we have data on over 97% of our outcomes. That's of our primary outcome, which is excellent. But there were some limitations as well. Usual care changed over time. When we set out to do the IMP study, there were no such things as primary care networks, for example, and the substantial number of clinical pharmacists that we now see in general practice was not evident. There is a lack of a robust measure for patient-reported outcomes, so that was a challenge to measure that. And then some of the secondary outcomes, because a lot of these were patient-reported, some of the data for that were missing. Why are things not improving when we're throwing all this effort to try and improve things? Well, perhaps it's just an intractable problem. These are very complex patients. There's substantial clinical uncertainty, and the argument can be made it's maybe just too big a problem. And it's interesting that there were these subtle, tantalizing hints that if I can use the term, easier patients who had fewer health problems, fewer medicines, that they might be actually improving. And of course, we also know that, from studies like the DEQUIP study, like the PINCER study, that these focused interventions work. So it's this, just when you deal with a big problem, that maybe there's a problem. Another reason why we might not see an improvement is possibly we're looking at the wrong patients. Maybe simply being on multiple medicines is not necessarily a problem. After all, there's lots of evidence that medicines make people better. So simply trying to reduce the total number of medicines might not be the way forward. And just because we were identifying people with 5 or more medicines who had a potentially inappropriate prescribing issue doesn't necessarily mean those were the ones that would benefit most. And then the other thing is possibly we're measuring the wrong outcome. So potentially inappropriate prescribing measures such as stop-start, such as the ones we used, are only a measure of technical quality of prescribing. What they don't capture is what matters to the patient, and patient experience and quality of life are hard to measure, and they are potentially insensitive to change. We use crude measures such as EQ5D and other such measures of quality of life, but these are not really likely to change substantially with the sorts of things we're doing in a medication review. Furthermore, things like hard outcomes like admissions and death, again, don't change. And again, that's possibly not a surprise if we consider that about 5% of all admissions might be attributable to an adverse drug event, for example. Well, that's only 5%. 95% of admissions are unrelated to that. And then how likely are you to be able to substantially shift things to make an overall impact on admissions through medication review alone? So in summary, this was a large, robust study of patient-level intervention for polypharmacy, and unfortunately didn't show any improvement in potentially inappropriate prescribing, with the exception of this very interesting observation that possibly less complex patients might improve. There was also a small improvement in treatment burden, which was good to hear, good to see, but not improvements in quality of life and adherence or drug count. But there were some other positives that came out of the study, and we found them as part of our process evaluation work. And Debbie's going to talk to that in the final section.
Thank you. Yes. So, findings of our process evaluation then. I'll take you through some methods as we work through. But as you remember, I mentioned earlier that we administered a patient experience survey post-review to all patients receiving the intervention. And patients could opt to receive this survey online or via paper, whichever they preferred. And our overall response rate was just over 72%, with patients completing questions related to the nature of their review. So things like the duration, the type of professional that they had their review with, and whether their review was in person or via telephone. We also asked patients how satisfied they were with their review, and also their perceptions of shared decision-making within it. And finally, we asked patients for their views on the review process itself and the outcomes for them and their care. We conducted interviews with 28 patients, 6 GPs and 13 pharmacists. These participants were selected via purposive sampling. And we did this to gain a wide range of practice and patient characteristics, and therefore a wide range of experiences. So all interviews were conducted via telephone or video call, and we used a topic guide for each of the interviews to help ensure that each interview covered the key aspects we were interested in. So during the interviews, we asked people to talk about their previous experience of reviews, their expectations and understanding of medication review itself, and then also their experiences of the IMP intervention. For our clinical observations, we took a similar approach. Sorry, I've skipped one there. I'll just go back. Yeah, for our clinical observations, we took a similar approach to sampling, and we audio recorded medication reviews, capturing a total of 27 recordings of patient-facing reviews and 17 recordings of the interprofessional discussions between the GP and the pharmacist. So for the analysis of the survey data, this was mostly descriptive, but for our interviews and audio recordings, we transcribed them word for word and analysed looking for key themes. And the analysis combined both themes based on existing shared decision-making approaches and also data-driven insights from the data itself. We brought together the findings from all 3 sources to look for common patterns and used the SHARE model to help us interpret them. And as you can see here, SHARE is a 5-step model which outlines key steps in the shared decision-making process. So it includes seeking patient participation initially, helping with understanding of treatment options, assessing values and preferences, and reaching a discussion together and evaluating that discussion. And this approach helped us identify themes across all stages of shared decision making, from involvement and discussion through to agreement and follow-up. So what did we find? Well, we identified several key themes in patient experiences of medication review. We found that expectations varied. So some patients were very open to changing their medicines, and others were looking for more to gain knowledge and reassurance. Some, however, preferred to keep things the same, and others felt less involved in decision making. We also found that relationships mattered. 75% of patients did not know the clinician conducting their review. Most reviews were done by pharmacists, which was generally acceptable, but some patients were uncertain about pharmacists' authority to change their medications. Patients reported feeling reassured by GP pharmacists, the GP pharmacist discussion that happened prior to their review, and were also felt reassured when pharmacists acknowledged when there was uncertainty around decision making. So looking at patient satisfaction now, overall 75% of the patients were satisfied, and most reviews were carried out by telephone. What really stood out was the role of shared decision making, with patients were twice as likely to be satisfied as shared decision making during their review increased. So looking at shared decision making in a bit more detail, a few key themes emerged. Pharmacists generally tried to involve patients early, though greater use of pre-review information could have helped set expectations and prepare patients. Just over half of patients received information during the review that they valued, but some had unmet questions, and this caused them frustration. Around 60% of patients felt their priorities were discussed and acted upon, and most felt that agreement was reached during the review, though some preferred a clinician-led decision-making approach, and others were comfortable to reject suggestions made by their reviewer. Verbal summaries were common and appreciated, but only 8% received a written plan and 21% had follow-up arranged. So looking at the patient accounts, patient valued reviews that were meaningful, involved them actively, and offered ongoing support. Improvements included information in advance of the review and a post-review summary document. From the clinician interviews and observations, we identified 3 key benefits of the interprofessional discussions. Firstly, teamwork and collaboration improved. Clinicians felt they'd gained a better understanding of each other's roles and working as a team. Isolated working was reduced, and there was greater, meaningful and consistent communication. And protected time also meant that two-way discussion was supported. The second benefit identified was learning together and building confidence. And clinicians valued hearing different perspectives and felt this supported learning. Pharmacists felt their confidence grew and also felt that patients' trust in them increased. And then the third benefit was working together to tackle more complex care. Collaborative discussions supported reflection, shared knowledge and planning, and this helped management of complexity and provision of more holistic care. And also clinicians felt it helped identify issues that might otherwise have been missed. And crucially, all of these benefits were observed only after a few patient reviews, and many clinicians wanted these type of discussions to continue after the trial. So we also identified several things that helped the interprofessional discussions worked well. A supportive practice culture, trust and valuing each other's skills, an equal standing between the pharmacist and GP, alongside shared goals around stopping medicines that were no longer needed, all helped improve teamwork and made decision-making more productive. Things that made the discussions harder, however, were lack of time, difficulty arranging in-person meetings and scheduling across multiple sites. And also the fact that usually only one GP and one pharmacist were involved. And all of these things limited the effectiveness of wider engagement of in these discussions. So to our key messages. Looking across all of our findings, one of the first things to note is that using multiple data sources gave us a rich, triangulated understanding of medication reviews. Of course, there were some limitations, such as survey response bias, and also some questions about how representative the respondents were. For patients, satisfaction was generally high. Most found pharmacist-led phone reviews acceptable. At the same time, our findings highlighted that there were some missed opportunities for open discussion and shared decision-making. Patients told us they wanted to be informed beforehand, prepared for the conversation, and have their priorities considered. And many also saw the review as part of a continuing process of care, so not a one-off event. Looking at clinicians, interprofessional collaborative discussion was clearly valued. These short, structured discussions between pharmacists and GPs were feasible in routine practice and helped build teamworking and communication, and also shared learning. This bringing together of different perspectives supported medication review and increased patient trust, but time pressures remained a significant barrier to making the most of these discussions. So looking at our findings as a whole and their implications for policy and practice. Firstly, I think it's important we incentivize more patient-centered reviews because we found that these enhance patient experience, improve patient preparation, and follow-up is valued by patients. Secondly, we should encourage interprofessional collaborative discussions. We've shown that these improve working relationships, skills sharing, and greater patient trust. Interprofessional discussions, however, should have protected time. They should be funded regular meetings with a named GP and cover multiple patients rather than being tokenistic or ad hoc. And also patients should be made aware that they've taken place. Thirdly, thinking back to the absence of improvement on patient safety, so our primary results that Rupert has presented, there's a need to revisit current review policy and focus upon defined problems and more patient-centered outcomes, which, as I demonstrated earlier, patients clearly value. And finally, the intervention was supported by a range of additional components, including training, incentives, feedback, and IT. While we've not really mentioned these in any detail today, our work with clinicians indicates that these elements were valued. So further work is therefore needed to explore the extent to which these components contribute to improvements in medication reviews within primary care. Thank you. So I think we'd be happy to take any questions and comments.
Thank you very much, Debbie. Just before we move into questions, so just draw attention to the Keeping in Touch slide that you can see now. If you'd like to sign up for the CAPC newsletter, you can receive regular updates on the research in our centre. Okay, so yes, we're going to move to questions now, and we're going to use the Q&A. So please, I'd really like to invite participants to ask questions. And while you think about those, I've got lots of them, but I'm not going to hog the question section. But I'll just ask one while people have a chance to think about the questions that they want answered. But first of all, thank you to both of you for that excellent presentation. I wonder if I could start by asking a question to Rupert. I was really interested when you said about this potentially being an intractable problem. And I mean, maybe not surprisingly, given my research is all around substance use and dependence, I was thinking about this from a behavioural context, and that in order to change prescribing, there's a behaviour change thing going on there amongst the clinicians. And I just wondered, is there any evidence that, and I think Debbie said the patients identified that it shouldn't be a one-off event, but is there any evidence that a single episode interaction, like in the study, could bring about a behavioural change in prescribing? Or, what's your thoughts there?
I think that, you may well have hit the nail on the head there, Jenny. The evidence for simple one-off reviews, which of course the vast majority of studies have examined, is very limited. And I think that's probably what we found with our own study. And even when you attach all the bells and whistles, the training, the performance feedback, the IT solutions, so on, it doesn't really shift things. And reviews, the way we teach students, they are an ongoing process of care. And yes, I suspect that if we did, do that and have a recurrent engagement with the patients, you are more likely to shift things in the right direction. Although that is, of course, more challenging to do. And of course, these studies, the IMP study was a substantial undertaking. You're not going to review people necessarily every 2 or 3 months, and to do that, I think would be very pretty intensive on resources. So I think there is a bit of a compromise to be reached between whether you can change things with a relatively minimal input. I mean, things like the Pincer study shown that you can change behaviour, certainly around very specific issues. It's just this broader issue when it's very big.
Okay, thank you. Right, we've got some questions come in. The first one is really about definition of polypharmacy. And when a patient should be called in for review, and what's your I think this is more a practice question than directly relating to the trial, but how would you define polypharmacy? Is it number of medications or specific medical conditions should be the focus? Is there anything there? Maybe that's one for you.
Shall I answer that, Debbie? I mean, I think that's a real difficult problem. I think, as I mentioned earlier, I think we don't know whether this is the right patient group. Polypharmacy from a strictly linguistic perspective is simply 2 or more medicines. People have defined it in lots of different ways: 5 or more medicines, 10 or more medicines. But we know the number of medicines. It's not just a fixed number that makes a difference. So it's really tricky. There are various bits of work, including stuff that Debbie and I are working on separately, and colleagues in Manchester as well have worked on, looking at alternative and more nuanced ways of measuring polypharmacy. But I think that's a real problem. If you can't measure the thing, then how do you actually know whether what you're trying to target is the right thing, the right patients?
Thanks. Okay, the next one is asking about whether you have any thoughts on how and why treatment burden potentially improved if the number of sort of medicines or medicines related problems didn't change, and if you're going to look into that further.
Well, yeah, well, I mean, the measure of treatment burden we used was the multi-morbidity treatment burden questionnaire, which was developed by Polly Duncan, Chris Salisbury in Bristol. It focuses on multi-morbidity, and therefore, rather than just drugs, there's more to it, more to treatment burden than simply how many pills you're taking, and therefore, although we didn't see a change in the number of medicines, there may have been other things that shifted in the way people, perceive the treatment, the burden of care. The other thing is that things like potentially inappropriate prescribing, as I already mentioned, is very technical, so it matters to, clinical pharmacologists like me or pharmacists like you, Jenny, but actually patients probably don't give a hoot if it's not making them feel unwell and not affecting them in any other way. So I think we're probably measuring other stuff, and there probably is further work to be done to try and understand the exact mechanisms by which treatment burden improved.
Excellent, thank you. Right, I think, Debbie, this might be one for you as trial manager. It's a great question. As you explained, the sample lacked ethnic diversity. And the question is, could you explain the strategy used to promote inclusivity and why you think it wasn't particularly successful in creating a more diverse sample?
Yeah, I believe we had recruited practices. We looked for practices that covered a range of socioeconomic, a range of populations, diverse populations, in socioeconomics, and then it was a random. So we then ran a tool to identify patients who were eligible for the study, and then randomly selected 300 of those for invitation. So I think our overall kind of trial design should have captured a representative sample of the population, but where I think it possibly where it failed, I guess, is perhaps with the materials that we use for the recruitment. And I don't know if Rupert wants to come in and comment on that, but the materials that we sent out, perhaps we should have looked at amending those into more accessible versions. I mean, they were all, when we developed them, they were all very much developed with patient and public involvement. But I think that might be the key step, because I think that was and I think it was some of the data we've got from practices. We saw that practices were struggling with, some practices were struggling to embed the intervention, or were unable to take parts in parts of the process evaluation. So we didn't capture great diversity in elements of the process evaluation either. And I think that probably nods to practices being very busy and therefore wanting to take part in research, but not having the capacity to take on board all of the elements that we were necessarily asking them. I don't know if there's anything to add to that, Rupert.
I don't think so. I mean, it's a difficult problem, and I agree. I mean, I think there is something about maybe one size doesn't fit all, and perhaps we need specific targeted interventions that focus on underrepresented populations, whether that be ethnic minority groups, whether that be LGBTQ minority groups, people with mental health, whatever. But maybe generic interventions are not the way to go, and we need to have things that are more tailored to individuals' needs.
Excellent, thank you. Okay, there's another comment saying that, an agreement that potentially the change in usual care over time during the study might have been an influence, but there's a question is wondering whether PIPs are actually still a useful target, in that they've been used in primary care sort of 15 plus years. So maybe most of the sort of inappropriate prescribing is in fact appropriate for many individuals. And so I think the question is it measuring the right thing now in modern context?
Yeah, I think that's probably right, Julian.
It's not what you want to be asked after you've done this study.
Well, I think it's right. I mean, one of the challenges, of course, coming up with a measure that is appropriate, and I think all the outcome measures that are out there are limited in some ways. I mean, in terms of the usual care improving, we didn't see any improvements in outcomes in the usual care group. So, despite all this, tons of pharmacists being rolled out and structured medication reviews, it didn't change things. So we didn't see an improvement in that. So it wasn't that simply usual care improved, nothing changed. But potentially inappropriate prescribing measures, I'm not sure they are necessarily the right thing. I think we do need a more nuanced thing. And I'm looking at your next question, Julian, which is around do you believe in further efforts to tackle polypharmacy? Yes, I do, but I think we probably need to forget about just throwing more energy at medication reviews. I think we need more nuanced and sophisticated approaches that acknowledge the different challenges that individual practices face and different patients face. I don't think one size fits all is probably the solution, and we need to come up with more clever alternatives. I think we should probably draw a line under let's do another medication review study. I think it's probably not going to make much difference.
That leads well into the next question, actually, and which I'm going to slightly combine with one of mine as well. So the question is, do you feel there's a cultural element that will take more time to allow patients as well as prescribers to change their dependency or focus on drugs? And the questioner has said it's interesting that less complex patients have a slight benefit, and this in itself could have a longer term impact over time. And my related point was, we have a lack of evidence for deprescribing compared to the effort that goes into evidence for prescribing, and whether that is part of these cultural elements that the questioner mentions. So yeah, basically, is it going to get better over time, and do we need a change in our focus and dependency on medicines and more confidence in deprescribing?
That was a difficult question to answer it, Debbie.
It's about 5 questions.
I'm not. There undoubtedly is a cultural issue here in terms of people's attitude to medicines. We're very much reliant on medicines. The old, come out of a consultation with a new pill is a sort of, it's almost a way of closing a consultation. So there is a cultural dependency on medicines, which I think you see in, as part of general practice. I think we're seeing it more broadly. We look at, the huge surge in the number of people using antidepressants, for example, for managing, low mood or things that are not necessarily depression, which is, of course, what the drug's licensed for. And, of course, there's huge surge in the number of people using these GLP-1 receptor agonists, the weight loss drugs, huge dependence on that. So there's a big cultural issue in terms of the way society uses medicines and our dependency on medicines that I think does need to change. But we also probably need to be thinking about how we train doctors from potentially an early stage at medical school and so on, to have change their attitudes to the way they use medicines and the way they start medicines in the first place. Fixing everything in a medication review once it's all gone wrong is a bit like shutting the stable door after the horse is bolted. You want to make sure these problems don't occur in the first place. And there are probably a number of approaches to that, including clever IT solutions and so on. But I think education for patient change, shifting culture is probably a really important thing. Debbie and I did discuss a study a few years back, how we could do that. And I think we felt that it was possibly a very, very difficult problem because it's such a massive change to achieve a shift in attitudes to medicines.
And I think the other thing, though, to mention is we are doing some work around deprescribing and how we and approaches to deprescribing of long-term medicines, particularly in patients with life-limiting illness where there may not be, those medicines may not be a particular benefit any longer. So we've done some work with patients and clinicians. And we're just finalising the analysis at the moment. So that's something to look out for, maybe for another webinar session.
Fantastic. Right, we're at 2:00. Our last question is quite long and complex. I wonder if, Rupert, you wouldn't mind looking at it and
I'm looking at it. It's very long and complex.
Would you like to type a response to the questioner while we wrap up the webinar?
Yeah, I'll try and do that.
And if the person who asked the question can stay on the call when everyone else leaves, Rupert will give you an answer. But I wanted to say thank you very much to Rupert and Debbie for your presentation. It's when a huge amount of effort, a huge study, and although you didn't get the result perhaps that may have been anticipated, I think when you reflect on it compared to the evidence Rupert presented at the start, it's perhaps not a surprise. And there's a lot we've generated today to think about around the future of medicines management and medicines optimization. So thank you both very much. Thank you to the audience for joining us. I know some of you have given up your lunch breaks to do so, and we really do appreciate that. So on behalf of everybody at CAPC, have a good afternoon, and thank you for joining us today.